So, welcome back everyone after a refreshing break. Now, we are starting with another important domain of pediatric dentistry, that is pediatric orthodontics and advanced pediatric dentistry. So, we have our first speaker, Dr. Ramanand Vignesh. Dr. Ramanand completed his undergraduate from Tamil Nadu Government Dental College, Chennai. He did his MDS from Maulana Azad Institute of Dental Sciences, New Delhi. He also served as senior resident in Government Medical College, Chandigarh. Dr. Ramanand is currently working as Assistant Professor, Adi Parashakti Dental College, Tamil Nadu. He has more than 25 publications in national and international index journals, also contributed to book chapters in renowned publishers. He is a PhD research scholar at SRM Institute of Science and Technology, Chennai. He also holds multiple scientific awards to his credit. So we welcome you, Ramanand. Can we have the presentation, please?
Thank you, Doctor. Good afternoon, everyone.
Hi, good afternoon, everybody. Today, I'm going to talk about preventive orthodontics, space maintenance, and management. So today, first we talk about what are the preventive measures which will prevent malocclusion, and after that, we are going to talk about what are the space maintenance and its factors influencing and indication, contraindication, and what are the types, and what are the recent advances and its modification. Okay, let's discuss about. So, we all know dental neglect, the primary and mixed dentition is the principal cause of malocclusion, the permanent dentition. So, we have three options to prevent malocclusion. First is prevent anything abnormal from happening, that is preventive orthodontics, and intercept any abnormal situation that is happening, that is developing. So, that come under interceptive, and correct an abnormality which is already developed malocclusion, that is corrective orthodontics. So, today we are talking about only preventive orthodontics. So the mixed dentition is a critical phase in child development, including jaw growth, eruption of permanent teeth, and the resorption of primary teeth. So, yearly loss of primary teeth can disturb the arch integrity by mesial drifting of the adjacent teeth and loss of space and its malocclusion. So, we all know the natural space maintenance is the primary teeth. So, we put all effort to preserve that to regain space and essential for the proper occlusion and eruption of the common teeth. So, according to Gray, 1966, defined preventive orthodontics as the name implies the action taken to preserve the integrity of what appears to be normal at the specific time. And also other authors, Profit and Ackerman has defined is a prevention of potential intervals with occlusal development. Okay. So mainly before occurring malocclusion, what are the steps we are going to apply to prevent malocclusion? So there's a concept called ideal orthodontic service. What is that? So for the malocclusion is going to happen, and if malocclusion happens, what are the treatment we have to? What are the ratio of the treatment? So the ideal orthodontic service should devote 10% observation and prevention, and 20% interceptive procedures. So and 25% partially corrective mechanotherapy, and remaining 45% will goes to full corrective mechanotherapy, that is surgical orthodontics. So this is the concept of ideal orthodontics service. So so most of the preventive orthodontics come under the 10%. That is observation and prevention. So it includes procedures undertaken prior to the onset of malocclusion in anticipation of developing malocclusion. So these are the factors. These are the factors which include the preventive group to prevent the malocclusion. We will see one by one. So first is education of parent and patient. So the education of parent is very critical. It starts uh, at the time of pregnancy. So ideally should begin before the birth of child. The parent should be educated on matters such as nutrition, mode of feeding, and maintenance of oral hygiene, and should also educate on proper nursing and importance of mother's milk and drawbacks of bottle feeding and care of child. So the mother should be educated on difference between the physiological nipple and conventional. That I'm going to explain in the next slide. And they should also educate on need of maintaining good oral hygiene and correct method of brushing. So these are the factors we have to educate parent as well as patient. So what is conventional and physiological nipple? What's the difference between them? So we all know that it's commercially available conventional nipple. The non-physiological and do not permit suckling by movement of tongue and lower jaw. So the child need more mouth opening and more pressure to get to suck the milk. So they cause suckling of milk, which later on leads to various orthodontic problems. But if you see in physiological nipples, that is also available. Is designed to permit suckling of milk, which are more or less resembles the normal function activity, similar to the breastfeeding. So this is main. This is the main difference. So, recommended oral age for the appropriate age. So, for 0 to 3 years, infant and toddler, the parents' brushing oral hygiene should be maintained under parental supervision. The moistened gauze or washcloth can be used to gently massage the gum and clean teeth. And they have to prescribe fluoride toothpaste, that is smear size, equal to smear size, that is equal to 0.1 milligram fluoride for less than 3 years old. If the child is preschooler, use pea size amount, that is equal to 0.25 milligram fluoride. So these are the appropriate amount of toothpaste, fluoridated toothpaste. The next is caries control. So whenever the presence of proximal caries, so there will be a loss of arch length due to movement of adjacent teeth in that space. So we have to detect early by using a biplane radiograph, and it should be restored properly. So the restoration should restore the mesodistal dimension of the tooth, but should not be over underextended, because it allows drifting of contiguous teeth or promote food impaction. So re-establishment of proper inclined plane and proper contouring, not only it will improve aesthetic but also normal function and stability of approach. So fastidious dentition, carrying of fastidious dentition is very important, because already I told it is ideal space maintenance for until the developing permanent or ready to erect oral cavity. So we put all effort to prevent early loss of dentistry. And extraction of supernumerary. So if the patient has presence of any mesodens or any supernumerary, we should intercept as early as possible to prevent the malocclusion. Okay, so these are all come under the preventive factors. So then next one is eliminating occlusal intervals. So all functional prematurities. So whenever we do restoration, there will be occlusal prematurities, and there is enamel pierce. It should be eliminated. So because it lead to deviation in the mandibular path of closure and also predisposed to bruxism. So it should be eliminated as early as possible. So the tooth shedding, the chronology of the tooth chronology, eruption and shedding time, we all should know about to prevent the malocclusion. So the gap of not more than 3 months should exist in the shedding of dentist teeth and the eruption of permanent tooth in one quarter. So this is very important. So next is ankylosity. So we all know ankylosis is the absence of periodontal membrane in a small or hole of root surface. So appropriate management of ankylosed primary tooth with the eruption or drift of other teeth begins to occur. So it should be diagnosed and surgically removed at the appropriate time to permit the permanent teeth to erupt. So next is frenal, abnormal frenal attachment. So, so the presence of thick and fleshy maxillary labial film will obviously cause midline diastema. So, if the space is 2 mm, we can, if the patient is 8 to 9 years old, if space is 2 mm in between the two central incisor, we can we let the patient to wait and watch. But if space is more than 4 mm, 4 to 8 mm, we have to take any we have to take any radiograph, and also we have to intervene. Okay. Otherwise, if the space is less than 2 mm, we can wait and watch. And if the frenal attachment is still abnormal attachment is still persist even after the canine eruption, permanent canine eruption, we have to intercept the problem. Okay, it should be diagnosed and treated at early age. So next is space control. So this we are going to talk about. The important part of the preventive orthodontics is the correct handling of spaces created by the untimely loss of plasticity. So what effects? The effects of premature loss of primary teeth or on oral function of oral teeth. So it will affect the masticative function if post teeth are lost, and if anterior teeth are lost, the speech will be impaired. So before speech development in a child, if teeth are loss of anterior teeth, it will affect speech development, so which might become permanent later. So next is supra-eruption. So premature primary tooth loss lead to excessive eruption of opposing tooth. So these are all effect of the premature loss of primary, and others are the psychological effect. The premature loss of anterior primary teeth especially will affect the appearance of the child and the position of permanent teeth. If the space closure after the premature loss of permanent teeth is most important sequencing for the permanent teeth to erupt. Okay. So coming to the space maintenance. What is space maintenance? This term was first coined by J.C. Brown in 1941. It's defined as the process of maintaining a space in a given notch, previously occupied by the teeth or group of teeth. So this we are going to discuss in detail. So what are the objectives of space maintenance? So first is preservation of physiological spaces, that is primate and devious space. So we all know primary space is present the primary dentition, levious space is present the mixed dentition. And second one is the preservation of integrity of the dental arches and preservation of normal occlusal plates. And in case of space anterior, it should aid in aesthetics and phonetics. So these are the main objectives that space. So what are the more common reason for the space loss? First is ectopic eruption of teeth. If the retained primary teeth if occurs, so there will be a ectopic eruption of primary teeth, and also premature loss of primary teeth and congenital basic teeth. So also it will also lead to space loss and also trauma and unrestored proximal caries lesion. I already explained about that, and delayed eruption and ankylosing of primary molars and disproportionate tooth size. So this all leads to space loss. So what are the factors involved in the space maintenance? First is the incidence of space loss. So almost all cases of yearly primary molar loss show some decrease in the arch length. That is mesial movement of permanent molars and distal movement of anterior. So younger the patient. If patient less than 6 years, there will be a more space loss. If maximum space is lost during first 6 months of extraction, most immediate loss within 76 hours. So this is very important point. So usually the maxillary space flows faster as compared to mandible space due to the porous nature and less cortical thickening. And the author Pedersen et al. Documented frequency of 50% population who underwent changes owing to the premature extraction. And other authors stated that the loss of second primary molar will cause greater space loss. The next factor is time elapsed since loss. So most of the space loss usually takes place during the first 6 months after the primary tooth is lost. So, with a tendency for space closure to occur more rapidly in maxillary than mandibular arch. So, this indicates when a primary tooth is extracted and factors indicate need for space maintenance. is best to insert an appliance as soon as possible after extraction. So whenever we extract the decayed teeth, unrestorable teeth, so so we have to insert a space maintainer, proper space maintainer as soon as possible after the extraction. Okay. So next is stage of development and dental age. In general, most space loss is likely to occur if teeth are actively erupting to the area left of the premature loss of the primary teeth. So the significant space loss mostly infused by stage of eruption of first permanent molar with a potentially particular high if primary molar is lost before or during the eruption of first permanent. So the amount of space closure usually less if permanent molars are fully erupted, occlusal interdigitation at the time of primary tooth loss. So similar situation exists if the primary molar has been lost prematurely and the permanent lateral incisor in the active state of eruption. So whenever the space loss occurs adjusted to the permanent first molar, the space loss will be more. So next to the eruption of permanent lateral incisor may result in distal movement of primary canine and encroachment of space available. In a mandibular arch, the lingual collapse of active segment may occur. So teeth actively erupting adjacent to the adjacent area have greater effect on amount of space loss than to fully erupted. So amount of space closure. Generally, the loss of maxillary second primary molar result in greater amount of closure, that is up to 8 mm of space loss in a quarter. But in, if the loss of mandibular second primary molar shows the greatest amount up to 4 mm in a quarter. So generally, the maxillary second primary molars leads to greater loss of space. So after the first primary molar erupted occlusion, the loss of second primary molar is still the significant space closure. So next is the important point: the loss of first primary molar with retention of second primary molar shows the minimal amount of space closure, as the second primary molar serves to buttress first primary molar closure after occlusion is established. So next is rate of what is the rate and amount of closure. So maxillary spaces have higher rate of closure than the mandible extraction space. So according to index in 1962, the rate of space loss after the second primary molar is 8 times greater than the first extraction. So according to Brixby 1951, the space loss is more in after loss of the second maxillary molars, but least is after loss of first maxillary molar. So this we have to. And same another author, Ronalman and Cylinder, same he also told upper primary second molar leads to loss of no space loss. That is 3.7 to 4.5. So next is direction of closure. How it will drift if space is lost. So maxillary posterior space is closed predominantly by mesially body and mesiolingual rotation around the algal root of the first one, permanent molar. In contrast, mandible space is closed primarily by mesial tipping of the first permanent molar, not by bodily movement, but tipping movement. Okay, along with the distal movement and retroclination of teeth anterior to the space. So this is how the closure happen in maxillary mandibular. So, according to Stewart and maxillary, all except one of the 12 extraction spaces closed by mesial migration distal to the extraction space. In mandible, space was greater than 2 mm, mainly by distal movement of teeth mesial to the space. So, another author study concluded mandibular space is closed predominantly by distal movement and maxillary space closed by mesial movement, the teeth posterior to the extraction space. So next is eruption timing of permanent successes. So in evaluating emergence of permanent teeth, the teeth normally erupt 3/4 of tooth is developed regardless of child grown stage. But the eruption timing of permanent successor may be delayed or accelerated after premature loss of primary tooth, depending on the developing status and bone density of the area and answer of the primary tooth. Okay. So the very early loss before significant root formation will result in delayed eruption timing. It may alter normal transition adjustment, notch length, notch width, and notch circumference. So if the permanent successor is 3/4 of root is developed. There is no need of space meeting. So next, amount of bone covering the unerupted teeth. So if there is bone covering, it can be predicted the eruption will occur. So so the guide is that the premolar usually requires 4 to 6 months to move through 1 millimeter of bone, as measured by the it can be measured by bibrane radiograph. So it will take 4 to 6 months to move 1 millimeter of bone. So abnormal oral musculature. So if patient has strong mentally muscle patterns, it will pronounce negative effect after the loss of mandibular, primary molar, or canine. And if a patient has thumb sucking habit, it similarly produces abnormal forces and collapse of dental arches after the loss of primary teeth. So this is all the another factor which influence the space maintenance. So next is congenital absence of teeth. So the success to congenitally absent or significantly malformed, the decision is challenging one, whether it can be closed or we can maintain the space. So it all about the clinician judgment. So next is coming to the diagnostic record. So so how we diagnose and how to select the space meter. First we do the clinical examination and take impression study model and do the space analysis, proper space analysis and radiograph. So these are the main record we have to keep it. So coming to the space analysis. So there are different type of mixed dentition analysis out there. First is Moyes mixed dentition analysis. So this requires only static model and no radiograph required. So and also we need probability chart for this. So measuring the mesodistal width of erupted lower, one can predict the mesodistal width of unerupted upper and lower canine from the 75% level of probability chart. Okay. So how to do this math? First, measure the mesodistal dimension of all 4 lower incisor and subtalar, and use the probability chart to find the mesodistal width of upper and lower canine and premolar for the upper and lower chart at 75% probability. And next is measure the distance between the distal surface of permanent lateral incisor and mesial surface of permanent first molar. So the amount of space left gives the space analysis. So next is Tanaka and Johnson. So this is most commonly used analysis among the postgraduates. So it predicts the width of unerupted canine and premolar using the width of lower incisor. So it has a good accuracy despite small bias toward overestimating the unerupted tooth size. So it does not require a radiograph or a reference table. So first, how to measure? If maxilla, we have to add the 1/2 of with the 4 incisor with the 11 mm, and if it is mandible, it add with 1/2 of mesodistal width of 4 lower incisor with 10.5 mm. It will give estimated width of mandibular canine and premolar and one quadrant, and simultaneously maxilla and mandible. So this is the formula here. So next is Nance mixed dentition analysis. So this is similar to arch perimeter analysis of permanent dentition. So we need a dental cast, millimeter scale, and periapical radiograph. So this is a radiographic method. So first is measure the mesodistal width of erupted permanent teeth and measure the width of each unerupted teeth, cuspid and bicuspid from the IOPA. And the total mesodistal width of all teeth in each quadrant will indicate space required to accommodate the permanent teeth. So we have to compare the space required and space available to arrive at arch. So next is Okawa mixed dentition analysis. This is also one of the radiographic method. So this is a formula here is actual width of primary molar divided by upper width of primary molar. So actual width we have to measure the cast, and upper width we have to measure the radiograph. So what will we will get actual width of unerupted premolar from both formula. So coming to the classification. So according to Hitchcock, there are different type of classification. Hitchcock and Raymond C. Crowe. Hitchcock given removal, fixed or semi-fixed, with bands or without bands, functional or non-functional, active or passive, and combination of this appliances. And Raymond C. Thoreau divided into removal, further divide removal, complete watch, and individual. So next is Hendrickson. He classified in fixed removal, fixed further given to class 1, class 2, and removal is acrylic wash. So what are the indications of space movement? So first is to prevent drifting of teeth, so maintain space and maintain aesthetic and restore the function of lost tooth, to prevent sequelae of periodontal and caries problem and economic erosion of teeth. So these are main indications. So contraindication. So if the meso distal width of underlying permanent tooth is less than the space present, and if the tooth is near the crest of ridge, or when the underlying permanent tooth is missing. So, but this is a judgment. And if radiograph extraction shows 2/3 of root developed with the successful. So we do not provide a space window for these factors. So what are the prerequisites of space window? So you should first maintain the meso with distal dimension of the lost tooth and should be functional at least extent of preventing the overeruption of opposing tooth, and should be simple and as strong as possible, and should be cleaned, easily cleaned, and not serve as a trap, and should not restrict normal growth and development. So these are the main prerequisites. So this is all overall type of space taken from an article Bowman et al. He divided the fixed unilateral space maintenance, fixed bilateral space maintenance, and removal space maintenance. So first, we'll see the removal space maintenance. So there are space maintenance that can be removed inserted in the oral cavity of the patient. So it can be functional or non-functional. So main advantage is easy to clean and permit maintenance of collagen. It restores the vertical dimension. It can be worn part-time, or it allows circulation of blood to the soft tissues. And also, if it is functional space maintenance, it will provide aesthetic, mastication, and phonetics. So even the regular checkup dental checkup can be done for if any caries detection. So there is enough space for the permanent teeth to erupt without changing the appliance in case of remote space maintenance. And it stimulates the eruption of permanent teeth, and band constriction is not necessary as like fixed space maintenance. And it also helps in prevent contrasting ambiguity, the extraction spaces. So what are the main disadvantages? So we cannot give a non-compliance patient. So it may be lost or broken by patient. Mostly if the patient is less than 5 years old, 4 or 5 years old, they won't be applied. And later jaw growth may be restricted if class or incorporated. And also it causes irritation to the underlines of tissues. So what it mainly indicated if the aesthetics are of important, and if abutment teeth cannot support a fixed appliance. And also cleft palate patient who requires observation for the palatal cleft, and multiple loss of distal teeth which may require a functional replacement. Okay, so these are the conditions removal appliance are indicated. So contraindicated one is patient non-patient patient non-compliant and allergic to acrylic, and patient has uncontrolled seizures. So acrylic postural culture. So this can be used in bilateral posterior space maintenance when more than one tooth has been lost per segment and permanent incisors have not erupted as such. So they replace the occlusal function. So here the problem encountered with these appliances failure to wear them, leading to loss of space, or failure to remove for cleaning can lead to soft tissue. So this is a modification for the full space maintenance. It's a Q's angel. It's a modified prosthetic approach when young children lose multiple teeth prematurely. So there is U-shaped denture will accommodate the natural teeth. It not only preserve the arch space but also restore key functions such as mastication. speech and aesthetics. So next, full complete denture. So if when primary teeth are lost due to ramen caries, that cannot be restored. Dentures not only restore but also aesthetics. So it can be subsequently adjusted to allow eruption of permanent molar lines. So then recombinant distal tissue space maker. So we all know when there is premature loss of distal second molar before the eruption of permanent molar, we give distal tissue space maker. So here tooth to be extractor is cut away from the stone model and depression made in the stone model to allow fabrication of the acrylic extension. So it should not given the children who are immunocompromised or bacterial endodontitis because complete epithelialization around the intraoral portion has not been demonstrated. So then coming to the fixed space maintainer, the Simsek et al. Defined there was no loss of abutment space during the follow-up. Here it can be considered as a successful fixed space maintainer based on the clinician and selection of patients. So come to the first panel of space maintainer. This is the most commonly used. So it's a unilateral fixed appliance in the posterior segment. So tooth distal to the extraction space is banded and loop of thick stainless steel 19 gauge wire soldered to it with mesial and touching teeth. So it is a simple cantilever design for the unilateral isolated space maintenance. So the Baroni et al. 1994, he studied that concluded no significant difference in the survival rate of bandal loop, inguinal arch, and Hans palatal arch space maintenance. And other authors also concluded it gave satisfactory results in terms of survival rate. So I quoted many authors. You can quote in your exams. So next is this is the recent one 3D banded loop space maintainer designed using CAD software. So it mainly made up of metal or photopolymer resin. It's a single unit. So it mainly saves the chair set time and lap time by eliminating the soldering and polish. So this is a it's a CAD cap monolithic zirconia mainly used for the space maintenance. Is for high avoid gingival trauma, and also if patient sensitive to the nickel allergy, we can provide this. So resin space maintainer. So this also made with the fiber composite, and main advantages is less chair side time and proper isolation and bonding time is essential for this improvement. So, but we can give mainly for single space loss. So studies concluded that surveillance rate of present space maintenance, but none of the studies have proved that it is superior over the metal space. So I quoted many studies related to that. So next is direct molded space maintenance. So it consists of stainless steel which directly bond to the adjacent teeth using the composite resin without orthodontic band. So this is also one of the modification. So it exhibited failure rate of 60% with a survival period of 9.2 months. So this is another study. So so this is now it's market available in the market prefabricated banded loop space maintainer. So prefab banded, so preformed stainless steel appliance used to preserve space following premature loss of pregnancy. So here the band is adapted to the abutment teeth and loop extend to maintain the space. So it is simple and cost effective. So next is crown and its modification of crown. If abutment teeth is highly carious, we can do pulpectomy. Then we can go to crown loop. Thanks. So higher survival rate seen in the crown loop as compared to banded. So next is lingual lodge. If the patient has multiple bilateral missing of posterior teeth, but the permanent incisor should be erupted. Mainly lateral is permanent lateral incisor should be erupted. So we can provide a lingual lodge. So it should be positioned the rest of the single of its approximately 1 to 1.5 of the soft tissue and should be stuck to lingual in the canid region and remain away from the primary molars and another premolar. So it high number of failures compared to pattern loop space maintenance and spelled according to Baroni. So other authors also I quoted. So this palatal arch, it should be given. It's similar to the lingual arch. It designed to prevent mesial migration of the maxillary molars. This we have to it is indicated in bilateral missing of posterior teeth and the maxillary arch. Due to time constraint, I am moving fast. So it has surveyed at 70% at the end of 36 months. So next, transpalatal loss. Suppose the patient has unilateral multiple loss of missing teeth, we can provide transpalatal loss. So next is distal shoe. It's also called intra-alveolar appliance. If the premature loss of second primary molar before the eruption of first permanent molar, we can provide distal shoe space maintenance. So here the Roche distal shoe, it's mainly the difference here is intragingival extension. So this is a modification at the distal shoe. So you can go through with this. So next is band and bond type. So abutment on either side of extension space are banded and connected to each other by the bond. So this is one of the modification of banded space maintenance. So this is a comprehensively put taken from an article Coburn et al. So you can go through indication advantage, overall space maintenance and the indication advantage. So what are the recent advances and modifications? So first is Hollywood appliance. If patient has suppose a patient is 3 years old, so if a loss of anterior teeth, so we can provide Hollywood appliance by doing banding on the second primary molar. So next is preformed band custom made loop space maintenance. Next is glass fiber, that is fiber reinforced. It gives the main advantage is less charge at time. The single visit we can finish it. So next is ceramic band loop. That's called RaRe space maintenance using CAD/CAM technology. So this is all one of the this is another lingual arch using CAD/CAM technology. A nickel appliance, if mesially tip of first permanent molar, we can this is an active space maintenance nickel appliance. So I provided many studies for your exam. The first is the Peroni et al. He concluded a 24-36 month interval transpalatal arch and banded loop space maintenance maintained 70% constant survey than the lingual arch. And Simsek et al. 95% simple fixed space maintenance surveyed at the end of 18 months. Okay. So this you have to go through. I provided many studies, related studies to the space maintenance. So this so more than 10 studies I reported. Please go through. So I'm concluding preventive orthodontics plays a key role in guiding normal occlusive development by eliminating or reducing the factors like. So overall, the preventive orthodontics reduce need for extensive fixed orthodontic treatment in the later stages. Okay. Thank you.
Thank you, Dr. Ramanan, for such an informative lecture. So as I can see, you have almost addressed most of the questions in the chat box. So would you like to share your concluding remarks?
Yes, doctor. Thank you for So thank you for the platform for the presentation. Is it audible?
Yeah, you're audible.
So I'm concluding. So there are many space meetings, and and also I quoted some articles. Please, the students, please go through. And there are exception cases in some questions they ask students to ask. In some cases, there is no definite space maintainer is indicated. In that case, we can, as per the clinician expert, we can customize the traditional space maintainer. So, for example, if one question was asked, if 3-6 not erected and 7-4-7-5 is indicated for extraction, so we can go for bilateral distal that is given in Nikhil Marosa's book. Please go through that. So in some cases, we can customize from the conventional space method. Thank you, Doctor. Thank you.
Thank you, Dr. Ramanand. Can we have the certificate? Thank you, Dr. Ramanand, for your valuable contribution.
Thank you, Doctor. Thank you.
Now we move on to our next session on interceptive orthodontics. So we have Dr. Nirabjit Kaur ma'am, who is a professor and head of Department of Pediatric and Preventive Dentistry, Punjab Government Dental College and Hospital, Amritsar. Ma'am had completed her graduation and post-graduation from Punjab Dental College and Hospital, Amritsar, joined Punjab Dental Education Services in 2008. Since then, she has been actively involved in the field of teaching and research. Ma'am is also a member of editorial board of International Journal of Clinical Pediatric Dentistry. She also has publications in various national and international journals, also a life member of ISPPD. Ma'am, over to you.
Should I start?
Yes, ma'am.
Should I start?
Yes, ma'am, please start.
A very good afternoon to all of you. Today's topic of discussion is interceptive orthodontics. So what interceptive orthodontics is? So it is that phase of science and art of orthodontics employed to recognize and eliminate potential irregularities and malpositions in the developing dentofacial complex. So according to Graeber, interceptive orthodontics refers to the measures undertaken to intercept a malocclusion that has already developed or is developing, and the goal is to restore a normal function. According to Ackerman and Profit, interceptive orthodontics can be defined as elimination of existing interferences with the key factors involved in the development of the dentition. Following the list of the procedures that can be undertaken in the interceptive orthodontics: serial extraction, correction of developing crossbite, space regaining, control of the abnormal habits, muscle exercises, removal of soft tissues or bony barriers to enable the tooth eruption, interception of the skeletal malformations. Is there any problem? So the contents of today's presentation will be starting with the introduction, then serial extraction, correction of developing crossbites, space regaining, then control of the abnormal habits, muscle exercises, removal of soft tissue or bony barriers to enable the tooth eruption, then interception of the skeletal malrelations, and then coming to the conclusion. Serial extraction. The term serial extraction describes an orthodontic treatment procedure that involves the orderly removal of selected decidus and permanent teeth in a predetermined sequence. Serial extraction can be defined as the correctly timed removal of certain deciduous and permanent teeth in mixed dentition cases with dental velar disproportion in order to elevate the crowding of incisor teeth to allow the unerupted teeth to guide themselves into improved positions and to eliminate the period of the active appliance therapy. So coming to the history, it started in 1600 by Peshan, the first person who pointed the extraction procedure in order to improve the regular alignment and crowding of teeth. Then in 1743, essay on the diseases of the teeth, Benon proposed the removal of deciduous teeth to achieve a better alignment of the permanent teeth. Then in 1929, Jalgren coined the term serial extraction to describe a procedure where some deciduous teeth followed by permanent teeth were extracted to guide the rest of the teeth into normal occlusion. Nance presented clinics on his technique of progressive extraction, and he has been called as the father of serial extraction. Then Hortz named the procedure as guidance of eruption. According to him, the guidance of eruption is comprehensive and it encompasses all the measures available for influencing the tooth eruption. So coming to the indications, serial extractions is directed towards severe dental crowding. It is best used when there is no skeletal problem existing and the space discrepancy is 8 to 10 mm in an arch. Then the premature loss of the deciduous teeth, then arch length deficiency and tooth size discrepancy, then absence of physiological spacing, lingual eruption of lateral incisors, unilateral deciduous canine loss and midline shifting, canines erupting mesial to the lateral incisors, canines erupting mesial to the lateral incisors, mesial shift of buccal segment, abnormal eruption, direction, and sequence eruption, gingival recession on labally displaced incisors, flaring ectopic eruption, ankylosis, etc., abnormal or asymmetrical primary canine root resorption, crowded maxillary and mandibular incisors with extreme labial proclination, deleterious oral habits, class 1 malocclusion showing harmony between skeletal and muscular system. Then coming to the contraindication, they're severely, they are contraindicated in cases there is congenitally absent or missing lower second premolars, extensive caries of the permanent first molars, severe class 2 and class 3 malocclusions of dental as well as skeletal origin, unilateral congenital absence of the teeth, abnormal tooth size, shape, color, etc. In cases of cleft lip and cleft palate cases, reverse overjet, deep bite, open bite, rotation, gross malpositions, and cross bites. In cases of space dentition, serial extraction is not indicated. Class 1 malocclusions with minimal space deficiency, as other procedures can be undertaken to correct that problem. So mild disproportions between arch length and tooth material that can be treated by proximal stripping. And some of the commonly used methods are described like Devil's method, Nance method, Tweed's method, and Moyer's method. First of all, Tweed's technique for serial extraction, it was given in 1966, and at the age of 8 years, it is started. The sequence is DC4. At the age of 8 years, all the 4 deciduous molars are extracted to maintain the deciduous canine to retard the eruption of the permanent canines. After 4 to 10 months of that extraction, all the erupting first premolar teeth are extracted along with all 4 deciduous canines. And then the canines and incisors are aligned. Then Devil's method has proposed a 3-step serial extraction at 8 to 9 years of age. The first is to extract deciduous canine. After 1 year, second step is deciduous first molars are extracted so that the eruption of first premolars is escalated. Then the third step is extraction of the erupting first premolars to permit the permanent canines to erupt in their place. So this is the most satisfactory order in most patients even today. The sequence followed is CD4. In some cases of a modified Devil technique is followed, wherein the first premolars are enucleated at the time of the extraction of the first deciduous molars. Then coming to the Nance method of serial extraction, it is a modification of Tweed's method, which involves the extraction of deciduous first molars, then followed by the extraction of first premolars, and then the extraction of decidus canines is done. So the sequence followed is D4C. Moir's method is in different stages. Stage 1 is extraction of all 4 decidus lateral incisors, which helps in alignment of the central incisors. Then stage 2 involves the extraction of all decidus canines after 7 to 8 months. It will help in the alignment of lateral incisors and provide space for the lateral incisors, permanent lateral incisors. The stage 3 will involve the extraction of all decidus first molars, which will stimulate the eruption of all first premolars. Then stage 4 will involve the extraction of all first premolars after 7 to 8 months, and it provides the space for canines and stimulates the eruption of canines. So the sequence followed will be B, C, D, 4. So here is a case report by Hashim et al. In 2024. He worked upon serial extraction. Is it worth to do or not? So he did a review of literature and he concluded that early intervention through serial extractions not only addresses physical dental issues, but also contributes to the psychological and social development of the child. By prioritizing the timely treatment, we can alleviate potential sources of distress and enable children to engage confidently in various social and educational settings, thus promoting their holistic growth and well-being. Another, Almeida et al., he did a follow-up of approximately 20 years on serial extraction, and the conclusion was the long-term follow-up of the clinical case reported in this paper demonstrated that undertaking a serial extraction protocol determined the relevant aesthetic changes that afforded an improvement of the patient's self-esteem, resulting in a positive social impact. Furthermore, the low cost of this protocol permits the use of this therapy in underprivileged communities. It is important to emphasize, though, that the early correction of tooth crowding by this protocol does not guarantee stability, but small relapses do not invalidate its accomplishment. Then coming to the next crossbite corrections. Crossbites can be interior or posterior. So first of all, we'll discuss correction of developing interior crossbites. So interior crossbites, crossbite is a condition in which one or the more maxillary teeth are lingual relation to that of the mandibular teeth. It is usually self-perpetuating condition which, if not treated in the early, has the potential of growing into skeletal malocclusion and may at later stages require major orthodontic treatments combined with the surgical procedures. So it is of 3 types: dental, functional, and skeletal crossbites. First of all, first therapy which we advise in clinics is tongue blade therapy. Blade rests on the mandibular incisors opposing tooth in the crossbite. Patient is asked to bite with a constant pressure on the tongue blade. Proper use of tongue blade for an hour or 2 a day for 10 to 14 days is sufficient to deflect lingually, erupting tooth into the proper position. Then dental velar anterior crossbites manifested as one or more incisors in crossbite, usually occurring due to the over-retained decidus teeth. Most commonly used appliance for correction is posterior bite plane with Z-spring. Z-spring fabricated with Adams clasp on primary or permanent molars and embedded in the acrylic. Label bow incorporated to align upper incisors into their final position after crossbite correction. For first week, the appliance is kept passive so that the child becomes comfortable wearing it. Spring is activated by gently opening the wire coils to push teeth into proper occlusion, activated every 2 weeks until crossbites are corrected. Then coming to the Catalans appliance, it is used to correct crossbites in young patients whose permanent molars have not yet erupted into occlusion. So Catalans is also used when there is a developing, the teeth are in erupting stage. So it is used on lower interior where appliance makes use of muscle forces and guides erupting tooth in the normal occlusion. It is constructed at a 45-degree angulation on lower incisors by acrylic or cast metal. This type of appliance requires full-time wear to be effective and efficient, and crossbite can be corrected in total for approximately 2 to 3 weeks. It is luted using zinc phosphate cement. Then is the fixed mechanotherapy. Maxillary incisors are tipped forward by 2x4 appliance, 2 molar bands with molar tubes, and 4 bonded incisor brackets. This is the best choice for older mixed dentition patients with crowding, rotations, and more permanent teeth in crossbite. After treatment completion, the fixed lingual retainer placed for 4 to 6 months for retention the incisors to new position. So here I must mention all of you that Catalan's appliance is given when the teeth are in erupting stage. Means when the child is of 7 to 8 years of age, the patient is not coming for crossbite correction. They usually come for some of the other procedures. So we have to check into the oral cavity that whether there is some kind of tooth anterior crossbite is developing. So it is your moral duty to examine the patient fully and explain the patient at that time that this will happen if it is not corrected. So sometimes patient may report with the developing crossbite, sometimes it's not. So at that stage, it can be corrected within 14 to 20 days by giving Catalan applies. Otherwise, when it is fully established, then the removable therapy you can give Z spring, the bite plate, and fixed biomechanic therapy using 2x4 appliance can always be given. Then functional anterior crossbites are the presence of occlusally prematurity, deflecting the mandible into the more forward path of closure. So it results from functional shift of the mandible seen in pseudoclastic type of malocclusion and are treated by eliminating the occlusal prematurities. Skeletal anterior crossbites, they occur due to skeletal discrepancies in growth of maxilla and mandible. Crossbite involves whole segment rather than one or two teeth. Occurs due to maxillary retrognathism or mandibular prognathism or both. It is intercepted by growth modification using myofunctional or orthopedic appliances. Then coming to the posterior crossbites, they can be treated using crossbite elastics that is used for single tooth crossbite involving molars stretched between maxillary palatal surface and mandibular buccal surface. These are to be worn day and night. The treatment should be continued for more than 6 weeks. Otherwise, the extrusion can happen. Coffin springs removable appliance consists of an omega-shaped wire placed in the mid-palatine area. Free ends of omega embedded in the acrylic plate. Spring brings about dental-alveolar expansion. Then quad helix is a spring that consists of 4 helices capable of dental-alveolar expansion of the molar and premolar region. Skeletal expansion in younger patients. Then coming to RME, rapid maxillary expansion. This bilateral skeletal crossbite can be treated by RME, wherein the mid-palatal suture is split. Then it's done by appliance that incorporates screws that are activated at regular intervals. Hyrex appliances can be used. So this is Amidala et al. In 2023 did a study to explore the management techniques for crossbite corrections, and he gave a case series demonstrating successful treatment strategies. So the cases mentioned above gave the satisfactory alternative methods for correcting anterior dental crossbites during the mixed dentition period. It is important to recognize the need for early diagnosis and correction. Early correction of simple and minor malocclusions as a part of interceptive orthodontic treatment can rapidly correct anterior crossbites using either removable or fixed appliances. Primary treatment not only restores aesthetics but may also reduce the complexity and duration of any subsequent required treatment. This can help prevent potential adverse effects on the growth and development of the child. Then Vishnu et al. Did comparative evaluation of 3 treatment modalities for correction of anterior crossbites in pediatric patients. That was a controlled randomized trial. And he concluded that fixed or removable prostheses that have comparable stability and favorable prognosis, they can be a viable treatment for anterior crossbites in 1 or more incisors in a mixed dentition. The before and post parameters for each group showed a substantial difference, suggesting that each appliance was successful in correcting the crossbite. The removable nature of the posterior bite plane with Z-spring, however, made it the least popular alternative and resulted in the longest treatment protocol. Conversely, the most widely accepted appliance was the 2x4 appliance. Then coming to the space regainers, it is an interceptive orthodontic appliance that is used to widen a narrow arch in cases of crowding or impaction, or to regain the space lost by early loss of primary teeth, and thus by distalizing the posterior teeth to create a space for the eruption of the permanent teeth. When space loss has already occurred and the space maintainer cannot resolve the issues, the space regainers effectively regain lost space and prevent further malocclusion. In case of maxillary arch, space is regained through the distalization of posterior teeth. In case of mandibular arch, devices such as lip bumpers and transpalatal arches are used. The ideal age for distalizing molars to regain lost space is between 7 to 10 years. Maxillary molars can be moved distally 5 to 7 millimeter per site, while mandibular molars can only be distalized by 1 to 2 millimeter per site. The proper treatment planning is essential and involves using the patient study models, periapical radiographs, and clinical assessments and sphelometric analysis. Then there are two ways to gain space. One is invasive procedure, the other is a non-invasive procedure. Invasive procedures involve proximal stripping and serial extractions, which are used to treat established malocclusions, but these methods are irreversible. So you should have done all the model analysis and the plan should be, properly it should have been planned, because these are not then reversible. You cannot change them. Then sometimes by doing this, then coming to the non-invasive approaches, the use of fixed or removable space regainers are often preferred for intercepting misalignments in the dentition. This is the list of the types of space regainers which can be removable or fixed. Removable includes Hollis appliance with jack screw, split saddle, dumbbell spring, sling slot. Space regainer, Hollis appliance with finger spring. Coming to the fixed space regainers are Jeffries appliance, lip bumper, open coil spring, space regainer, lingual arch with low coil spring, Gerber space regainer, King's appliance, and Hotz lingual arch. So Hollis appliance with jack screw incorporates an extensive screw in the space and works by expanding the plates anterior-posteriorly and is activated one turn 0.25 millimeter every other day, slow maxillary expansion, and one turn in the morning and one turn in the evening for RME, that is rapid maxillary expansion. Lip bumper is constructed using a heavy labial arch bar with an acrylic flange in the anterior region to prevent contact with the lower anterior teeth. This appliance is used in cases where bilateral movement is required, as it relieves lip pressure, which can then be redirected to distalize the molars. This is achieved by incorporating loops in the arch wire before it enters the buccal tube and by utilizing coil springs. The lip bumper is specifically for the lower arch to gain space or distalize molars, and its counterparts in the upper arch is the Denhort's appliance. In this appliance, molar bands are fitted on the permanent first molar and the molar tubes are welded onto the buccal side of each band. A labial arch wire is engaged in the buccal tube and an acrylic button is prepared in the labial vestibule. The lip bumper transmits forces from the lips directly onto the buccal aspect of the first molar and enables its distalization. It is also useful for uprighting mesially tipped molars to lengthen the arch. Coming to the Gerber's appliance, it's a band. In this, a band is prepared for the abutment tooth and fitted, and the mesial surface is marked for the placement of U-loop, which may be stabilized by welding or soldering. The wire U assembly is placed in the molar tube and the appliance is allowed to contact the tooth mesial to the edentulous space. An eyelet may be welded to the flattened part of the tube next to the band. Weldable tube stops are soldered on the wire portion. Lower right and open coil spring sections are cut to fit over the wire between stops and ends of the U-tube. Then coming to the Hotz lingual arch, another method for moving molars distally utilizes the looped Hotz lingual arch. Hotz lingual arch is indicated in situations where the permanent tooth moves mesially rather than distal movement of the mesial teeth, and also in the cases where sufficient space is present for the eruption of permanent second molars. So this is a review of literature for space regainers in pediatric dentistry, and it explains that fixed appliances are favorable in cases where there is more than 3 millimeter of space lost or bodily movement of tooth is needed. If the space lost is due to the mesial tipping and less than 3 mm, removable appliances are used. The modification of space regainers are developed to maximize the benefit. and reduce the disadvantages. The use of digital aided manufacture can also be considered in the future. Then another review article on space regainers in pediatric dentistry explains that the proximal stripping and serial extractions are irreversible and invasive techniques for treating a malocclusion, while space regaining with removable and fixed space regainer appliances are non-invasive techniques. They help in the interception of malocclusion. Coming to the oral habits, Dorland defines habit as a fixed or constant practice established by frequent repetitions. Buttersworth defined habit as frequent or constant practice or acquired tendency which has been fixed by frequent repetitions. Matheson defined oral habits as a learned pattern of muscular contractions. And Boucher defines habit as a tendency towards an act that has become a repeated performance, relatively fixed, consistent, easy to perform, and almost automatic. This definition actually explains what habit is. Then coming to the different habits, like thumb sucking is most commonly seen in pediatric patients. The clinical features will be posterior crossbite, dishpan thumb, hypotonic upper lip, high palatal wart, protruded maxillary incisors, localized open bite. So the methods which we can incorporate, first of all, is beta hypothesis, in which we tell the patient to sit in front of the mirror and perform the habit. So this is based on the psychological learning theory. Then thumbs home concept, several kind of clothes are wrapped and like that. Then bitter solutions can be applied. If any among these is not successful, then modified bluegrass appliance can. Then is a tongue thrusting habit. Clinical features include proclination of anterior teeth, midline diastema, open bite, then due to the anterior tongue thrust or the lateral tongue thrust. So we can give palatal crib or palatal crib with spikes. Coming to the mouth breathing, it could be leading to the long, narrow face, narrow maxillary arch. So mouth breathing gingivitis, increased caries incidence. The management is with the oral screen that can be modified with the holes in it. Other management techniques can be lip exercises or monoblock activators. Then bruxism is basically usually due to underlying psychological stress. Clinically, you can see worn out occlusal surfaces, muscle soreness, temporomandibular joint pain, and periodontal trauma. So their night guard can be given. Then lip biting. Again, it is basically due to the underlying stresses. So first, protocol in treating bruxism and lip biting is to psychologically counsel the child, know the underlying cause. Then act of lip biting can lead to red ulcer formation. So appliance usually for localized for lip biting with the oral screen and lip exercises can be then given. Then coming to the self-destructive habits, chewing of the inner aspect of the cheek or pickling of the gingiva with fingernail, broken fingernail in gingiva. So here again, self-harming habits are always related with the underlying psychological stresses. So you should firstly inquire, gain the confidence of the child. Psychologically, counseling should be done. That should be the first prerogative in case of bruxism, lip biting, and self-destructive habits. In case these are not successful, then you can give full mouth and other management strategies can be given, like oral screen. So Zamir et al. Did a single and so he concluded that this modified quad helix design with the roller can be considered as an optional treatment strategy for simultaneous interception of sucking habit and correction of its resulting dentofacial deformities. So another study which showed that the treatment of tongue thrusting habit using modified blue glass appliance concluded that this case represents the use of modified blue glass appliance with the roller as a positive reinforcing approach to correct the tongue thrusting habit. When the patient played on with the roller, it created a new habit, thus breaking the old habit of holding true. For the proper way to eliminate the bad habit is to replace them with the good ones. So then coming to the muscle exercises, the indications of various muscle exercises, for example, first of all, masseter muscle exercises is required in case of weak masticatory functions. When the patient complains of reduced biting force, hypertonic muscles in patients with soft diet habits. Some children, the parents pamper them so much that they are not used to eat properly the good food. They are using the soft diet only. Vertical growth patterns or open bite tendency, post-treatment muscle strengthening to improve stability, patients with poor chewing in efficiency, and then coming to the tongue exercises which are indicated in case of tongue thrusting anterior or lateral, anterior open bite associated with tongue habits, abnormal swallowing, speech problems, lisping, improper articulation, mouth breathing cases, relapse cases due to the tongue pressure. Coming to the lip exercises which are indicated usually in cases of lip incompetency, that is the inability to achieve a passive lip seal, class 2 div 1 malocclusion cases, then hypertonic upper lip or hyperactive mentalis muscle. The muscle exercises for masseter is to clench the teeth while counting to 10, relax for 10 seconds and repeat until the muscle feels fatigued. Exercises for circumoral muscle is stretching of the upper lip to maintain the lip seal, massaging the lip, button pull exercises, tug of war exercises, holding and pumping of water back and forth behind the lips. Then exercises for tongue are one elastic swallow, tongue hold exercises, then two elastic swallow with the hold pull exercises. Then coming to the removal of the soft tissue and bony barriers. Sometimes over-retained primary teeth, fibrous or bony obstructions, ankylosed primary teeth, and supernumerary teeth are causes of the non-eruption of the sexagenous permanent teeth. In those cases, we have to remove those supernumerary teeth as early as possible. You must have seen in OPDs, the patient will come that the permanent central incisor is not getting erupted. So clinically, it looks like there is no problem, but when you will take the OPG or the clinical IOPR of that region, sometimes there is some kind of supernumerary teeth overlying there. So in those cases, you have to, remove those supernumerary teeth first. Then if the permanent tooth fails to erupt because of the fibrous or bony obstructions, its eruption may be stimulated by surgically exposing the crown. Then we can wait for some time to erupt after the exposure at its own. But if we feel that it clinically, you can assess that if it is difficult to, come out at its own after surgical exposure, then we can, give fixed therapy, putting on the brackets and pulling it with wires. Then surgical procedures involving excision of the soft tissues and removal of any bony overlying the crown of the unerupted tooth. The extent of the tissue removal should be such that the greatest diameter of the crown of the tooth is exposed. Then interception of the skeletal malformations. A functional appliance is a specialized orthodontic device designed to modify jaw positioning and dental alignments by influencing the muscles of the face, primarily used to correct malocclusions by guiding jaw growth during a patient's developmental phase, particularly when they are still growing, and can be either removable or fixed, working by applying forces to the teeth and surrounding bone to achieve proper alignment through the altered muscle functions. So oral screen, known as the vestibular screen, it was introduced by Neville in 1912. It has no active component. The mechanism of action is when the oral screen is designed, the contact of the labial surface of the incisors, then the forces of the perioral musculatures are transferred onto it, and this helps in their retraction. The oral screen keeps the forces of the cheek and lip musculature away from the incisors during the functional movements. Hence, the tongue is free to act on the lingual surface of the posteriors, resulting in the expansion of the narrowed arches. It should be worn by the patient every night and also during the day when possible. The patient is instructed to perform lip exercises several times in a day for a few minutes, that is 30 to 45 over a 24-hour period. Then upper and lower lips should be kept in contact with each other at all times to enhance the effect of the appliance and to improve the lip seal. So this is, oral screen with the modifications. So for mouth breathers, the holes are, engraved into it, and frequently on the subsequent widgets, when the habit of mouth breathing is reduced, then the holes can be filled later on. Then this is double oral screen, then HOTS modification. Then coming to the twin block, These are the bite blocks that effectively modify the occlusal inclined plane to induce favorably directed occlusal forces by causing a functional mandibular displacement. Upper and lower bite blocks interlock at a 70-degree angle and are designed for full-time wear, taking advantage of all the functional forces to the dentition, including the masticatory forces. The most common fault in thin block construction is to make the block too thin. In such conditions, the patients can posture out of the appliance, reducing the effectiveness of the treatment. An important principle is that the block should be thick enough to open the bite slightly beyond the freeway space. On average, the blocks are not less than 5 millimeter thick in the first premolars or first acidus molar region. This thickness is normally achieved in class 2 division, div 1, deep bite cases by registering 2 millimeter vertical interincisal clearance. Then coming to the Frankel appliances, the rationale is, according to Frankel, is the primary aim to of the functional therapy is to recognize a faulty postural performance of the orofacial musculature and to treat it by orthopedic exercises. The mechanism of action is that the Frankel applies the functional matrix concept and terminology of Moss to explain the basis of design of his appliances. When faulty muscle posture results in a compromised relationships between maxilla and mandible in a growing child, the appliance is designed to alter the biomechanical conditions in the periosteal functional matrices of these bones. So the types of Frankel regulators, functional appliances are the Frankel regulator 1 is used in correction of class 1 and class 2 div 1 malocclusion. FR1A used in class 1 malocclusion with minor crowding. It is used in delayed development of the basal bone and dental structure. FR1B used in class 2 div 1 malocclusion with deep bite and overjet less than 7 millimeter. FR1C used in severe class 2 div 1 with overjet more than 7 millimeter. Then functional regulator 2 is used for the correction of class 2 div 1 and in class 2 malocclusions. Functional regulator class 3, this is used for the treatment of class 3 due to maxillary deficiency. Functional regulator 4 is used for the treatment of open bite and bimax protrusion. Functional regulator 5 is functional appliances that incorporates headgear. Functional regulator 5 is used in high angle cases. So the conclusion is the management of space problems in mixed dentition plays an important role in pediatric dental practice. An understanding of the development in the primary and mixed dentitions help in deciding when and how to intercept the malocclusion due to premature loss of the decidus teeth. Proximal stripping and serial extraction are irreversible and invasive techniques for treating a malocclusion, while space regaining with removable and fixed space regainer appliances are non-invasive techniques and help in the interception of malocclusion. So thank you. I mean, in view of the final exams of MDS people, so the questions which you can get is long essay type question in which you can be asked about define interceptive orthodontics and discuss in brief about all the procedures undertaken in it. So then you can explain all of these. But you can also be getting small questions of, I mean, not of essay, 25 marks, in that any of the procedures discussed here can be asked. So you must mention, first of all, definition of whatever thing has been asked, then indication, contraindications, I mean, procedure for making, and then you should quote the relevant studies related to that. So, so you should, I mean, you should have gone, I mean, different kind of study patterns. And one most important thing that the MDS students miss in clinics is that when a patient is coming, suppose for a restoration of any tooth, so you will be, I mean, you will be looking upon the filling part only. So you won't be looking that there is one developing anterior crossbite also present in that tooth. So this patient should be taken up for a twin block. So please look in detail in the whole oral cavity. When a patient is coming for single restoration, you have to examine the whole mouth, and it is your moral duty to explain everything that is not normal at that specific time period and whatever need to be done. Then the decision is on the guardian's part, but you have to guide. So thank you.
Thank you so much, ma'am, for such an elaborative lecture. Ma'am, there are many questions in the chat box.
Yes.
For example, can you please explain about wearing instructions of oral script? How long and for how many days?
So it should be worn whole night and for 1 to 2 hours in a day when possible. So I mean maximum time during night it should be worn.
Okay, thank you, ma'am. And another question, how to calculate the length of coil to regain space in Gerber space regainer?
So space regainer, can you please repeat the question?
Ma'am, how to calculate the length of coil in Gerber space regainer?
So the space required, this is, it should be 1 to 2 millimeter to ensure the activation of the space.
Oh, thank you, ma'am. There are many other questions. I think you would be able to answer them at your convenience in the chat box.
Okay, fine.
Thank you, ma'am. Thank you so much for your lecture. Can we have the certificate, please? Ma'am, kindly accept this certificate as a token of appreciation from ISPPD. Thank you for your
Thank you so
valuable
much.
contribution, ma'am.
Thank you so much.
Yes. So with that, now we move on to one of the most interesting and clinically relevant topic, molar incisor hypomineralization and other developmental defects of enamel. We have Dr. Neeti Mittal ma'am with us, who is an accomplished academician, clinician and researcher with more than 14 years of experience in pediatric dentistry. Ma'am completed her MDS from PGI MER Chandigarh and holds a PhD in maxillofacial surgery. She is a qualified Indian patent agent with multiple patents and copyrights, secured 2,500 research projects within 18 months, extensive publication record in high impact index journals. Her key research areas include MAH, preventive dentistry, pediatric sedation, and caries risk assessment. Ma'am is also the recipient of Young Pedodontist Research Award by ISPPD and multiple national research awards. Editor-in-chief and editorial board member of reputed index journals, expertise in evidence-based pediatric care, research mentorship, and innovation-driven dentistry. Ma'am, we are very happy to have you here. Can we have the presentation, please?
Everyone, today's session is on molar incisor hypomineralization, and I think that it's going to be challenging for me to cover this topic in half an hour. But let's see how much we can do. And greetings from IDST Modinagar. Before we go into the details of MIH, first we need to understand that enamel cannot repair itself, and there can be a lot of architectural flaws in amelogenesis. Like if you see the picture on the left is for the normal enamel. If you see in the middle, it is showing a quantitative defect, and we call this hypoplasia. The thickness of the enamel is gone, and the prisms are tightly packed, but in between the chunks of the prisms are bone, which will clinically reflect as pits and fissures. And if you see the picture on the right, this is representing the qualitative defect that is called as hypomineralization. So the thickness is normal, the volume is normal, but is there the pores, highly porous sponge-like structures and degraded internal scaffolding. So the outline is same, but the porosity is there, and this is what manifests as MIH, which is a chronological qualitative defect of enamel formation. This is a generic definition of MIH to understand, and it primarily affects the first permanent molars and frequently permanent incisors. But in this case, we'll say it can manifest on any teeth, actually, in any teeth in the dentition, in the permanent as well as primary teeth. And why we are studying about the MIH? Because of its global prevalence and increasing clinical recognition and so difficult clinical management. We'll see how difficult clinical management and so many challenges associated with this. And previously, historically, before this term MIH came into being, so many terms were used to define it, like the non-endemic stained enamel, idiopathic enamel hypomineralization, dismineralized first permanent molars, cheese molars, hypomineralized first permanent molars, non-fluoride hypomineralization. So what it led to? It led to confusion, like complete non-homogeneousness in the epidemiological study. So how do we compare data? There was a need to come up with a consensus terminology, and this need was fulfilled by 6th annual conference of EAPD in 2003, and what they coined the term MIH, seeing that it involves the molars and incisors most commonly and simultaneously. And then with the terminology, they also came up with a framework also, like the MIH, they defined for the first time that the MIH comprises of the demarcated opacities with the distinct borders. It has to be more than 1 mm of the defect to be considered a positive finding. And interestingly, the cervical enamel is typically spared, and post-eruptive breakdown, atypical restorations. We'll see what atypical restorations, and then hypersensitivity. In the coming slides, we'll delve into the details of all these things. Before we go further, let's see what about the mineral gradient in MIH. Like in the normal enamel, you see that the hardness 350 hardness number, while here it is very, very less. Why? Because as I already told, the mineral content is less. And in normal enamel, the surface enamel is highly mineralized. Here, the surface enamel is poorly mineralized. In fact, on DEJ, you may see that the surface, the mineral content is higher. So we say inverted mineral gradient. And how this manifests clinically as the diffuse, the demarcated opacities with the clear-cut borders, the intact cervical enamel, the color ranging from white, cream, porous, yellow, brown, and the thickness of the enamel remains normal. Another interesting thing that it may affect any tooth at once or so many teeth together, but not to the same extent. Some teeth may be affected very badly, these may be broken down, while the same teeth in the contract can be pristine or normal. These are the pictures to show the clinical presentation of MIH. The first is showing the creamish white opacity. You can see the clear distinct borders. It is a demarcated opacity. Then we are showing the yellowish brown opacity. Again, the distinct boundary is there. Then post-eruptive breakdown. You can see that the cervical enamel is spared. Now coming to atypical restoration, which we see in detail in the coming slide. Another case showing the breakdown, and another case showing the simultaneous involvement of first permanent molar and deciduous molar. As I told that it is asymmetrical, it can affect any teeth. So we need to understand that it is not only molars and incisors are involved. Other teeth can be involved. Like in one type, molars and incisors can be involved together. In the others, molars may be affected alone, or incisors may be affected alone. And then in one type, molars, incisors together with any other tooth in the arc. And in the last type, interestingly, here no first permanent molars can be seen to be involved, but any other tooth can be developed. And this was the classification scheme developed by us on the basis of a large data set, and we again validated it, and we found the same 5 phenotypes in population affected with MIH. Now coming to MIH associated atypical restoration. Why atypical? Because usually the caries is happening either in the contact areas or in the bitten fascia surfaces. Here, the innocuous, the smooth surfaces are also involved. Mostly there is buccal extension, lingual extension. Another hallmark thing is presence of the opacities at the boundaries. Here again, you can see the opacity at the boundary. Now, if we see that why hypersensitivity is developing here, because of the enamel which is porous, there is bacterial penetration, this continuous bacterial ingress, continual bacterial toxins, their products, their metabolic products, they lead to subclinical low-grade inflammation. This subclinical low-grade inflammation is sensitizing the nerve endings. Now, what is an outcome of this hypersensitivity? can be to cold air, or even to toothbrushing. So it makes the maintenance of oral hygiene also difficult, and this further compromises the tooth, which is already weakened. And in clinical consequences, we'll say that it also increases the dental anxiety. So when a patient is coming to clinic, the child is already anxious, and you may need additional behavior control measures. And because of this, because the nerves are inflamed already, so the anesthesia is difficult to be achieved. In fact, articaine is considered to be recommended anesthesia in fact of lignocaine. And if you see the prevalence of MIH, it is like globally average prevalence is 12.9 to 14.2%. And you see in these also 1 to 4 permanent first molars per patient are affected. And 41.8 of yellow point opacities progress to dental exposure. And I have selected only a few of the studies to show you a range, because as a postgraduate student, if you are supposed to cite some studies in your answer, but then you cannot, memorize them all. So maybe just citing the systematic review by Swedeke or this how is sufficient. And some of the hallmark studies you can highlight, like it is very low in China and very high in Brazil. In Europe, it is again very and moderate. And we also need to know about our country. So I'm only sharing some of the very initial studies, and overall prevalence is 6 to 10% in India. And if you see that the first study was done and in Ahmedabad, and it showed 9.2%. Then the second study was done in Chandigarh, and it showed a prevalence of 6% approximately. Now coming to how do you distinguish MIH from other developmental defects of enamel. Hypoplasia, like I told in the very first slide also, it's a quantitative defect where the thickness is reduced, and there will be pits, fissures, grooves, and areas of missing enamel with smooth margins. And in MIH, it's a qualitative defect. The thickness of enamel is normal mostly until unless it undergoes post-eruptive breakdown. And we need to see that, like when the tooth is erupting, then the PEB post-eruptive breakdown is not present. While in the hypoplasia, the defect is present at the birth, and the margins of the defect are smooth. While there in the PEB, the margins are irregular but distinct. This is the clinical picture showing hypoplasia. You can very well appreciate that the outline of the tooth is affected, the tooth structure is gone, and here is also pitting on lower incisors. And how do we compare MIH with the dental fluorosis? We say that we have already talked that MIH has demarcated opacities, while fluorosis distinctly has diffuse opacities. And MIH is asymmetrical defect, fluorosis is symmetrical defect, and MIH has predilection for first permanent molars, and fluorosis is mostly generalized. And one more important thing, MIH is weakening the tooth structure. Fluorosis is aesthetic thing. Mostly it is not weakening. It makes the teeth resistant to caries. Why? Because everyone knows fluorides makes the teeth caries resistant. This is a clinical picture showing fluorosis. You can see that generally, there is a generalized involvement, or teeth are involved, and the opacities are diffused. If we compare it with a disorder like amelogenesis imperfecta or AI. AI is characteristically, we say that it is generalized, similar to fluorosis. It is symmetrical, but it is often hereditary, and there is uniform involvement. And you will see AI will also have hypoplasia like the low tooth structure. And in these clinical pictures, you can see that AI is involving the teeth. Generalized involvement is there, and there is pitting and loss of tooth structure as well. If we compare it with the white spot lesions, then you can very well appreciate that the white spot lesions are acquired lesion, and if you are making a tooth or the environment wet, then the white spot lesion will disappear, because teeth will the water will occupy the porosity of the enamel, and the white spot lesion will not be visible. While in MIH, even if we wet the tooth in the wet environment, the protein is there, so the refractive index doesn't change depending upon the presence of water, and it is still visible. That is why the EAPD diagnostic criteria says that teeth are to be observed in wet conditions, so that you can differentiate between the MIH and white spot lesions owing to caries. And another is the location of defects. In MIH, mostly occlusal buccal surfaces are involved, cervical defects are spared. While in white spot lesions, the cervical defects or the areas where the plaque is accumulating, those areas are affected. So this is the clinical picture showing the white spot lesion at the cervical margin. Here also, here also. Now coming to first, we have to see there may be few other defects, whether the defect is symmetrical or not symmetrical. So if it is not symmetrical, then it is mostly Turner's hypoplasia or MIH. Now, how to differentiate Turner hypoplasia? A positive history in this case will be helpful, and mostly that is hypoplasia, and MIH is hypomineralization. We are studying so much of MIH, and how we need to know how the data for the MIH was standardized. Like initially I told you there was confusionist terminology. So it was not just confusionist terminology, there was confusion in this recording criteria also. And because of this inhomogeneous recording criteria or recording indices, some were leading to underdiagnosis, some were overdiagnosis. Like we'll see one criteria, very popular criteria soon after this slide, that led to underdiagnosis. That is modified DD index. The very old studies like the 80s or 90s, you will see those studies utilize the DD index. Now the component of DD index that was used to record MIH was obesity. So only one parameter, like the demarcated opacity or diffuse opacity. So this index was not capable of recording PEB, atypical restoration, extractions owing to developmental defects. And so the prevalence reported by MDD index was definitely less when we recorded it with EAPD index. So the EAPD index, although we have already seen the criteria that there are the 4 main categories, demarcated opacities, post-eruptive enamel breakdown, atypical restoration, extracted molars due to MIH. And why? It is very simple, very distinct categories, easy to use, and it is accepted worldwide. And it is this index which has made the comparison of the prevalence and comparison of the clinical findings across the globe possible. But what are the limitations? We'll say that it is not giving us very details about the treatment. It is not giving us details about the severity. So in 2010, EAPD modified its criteria and included the severity classification into the recording criteria. 2 categories only, mild and severe. Basically, mild tells you need minimal treatment and follow-up. Severe tells that you need definitive treatment, because in the mild, there are demarcated opacities only, no enamel breakdown, no sensitivity, minor or no aesthetic concern. While in the severe, there is PEB, post-eruptive breakdown, there may be caries, there may be persistent hypersensitivity, and it could have led to functional impairment, significant aesthetic concern. So what we need to do, we need definitive treatment for severe MIH. But then again, the limitations are very broad categories. So although Machu tried to improvise this criteria by including a moderate category, interim category, but still I'll say that that is also not good enough, while the treatment need index is a better measure. And again, the extent of defects was not noted by EAPD, like how much of the tooth surface is involved, how much tooth area is involved. This was made possible by the Ghanemann surface involvement criteria. Like they say that less than 1/3, 1/3 to 2/3, or more than 2/3 involvement was there. And it also came up with 2 forms, short forms for screening, long form for detailed epidemiological recording. We have read so much about MIH, how it looks, where all it is found, how it is recorded. Now we need to understand what causes MIH. We already saw that amelogenesis is a very sensitive process, and any metabolic shift will lead to defect in mineralization. And also important point is that this defect is chronological, like any it correlates with the time period of inserts. Now, how the timing dictate the insert? If in the amelogenesis, in the secretory phase, when the enamel matrix is being secreted, then defect is happening, then we say that the thickness or the structure of the tooth is affected. And This is called enamel hypoplasia. While in the maturation phase, when almost the structure is completed, but the further mineral deposits are happening, then at that stage, defect is happening, that is called as hypomineralization. Here, the disturbed protein removal is affected because proteins are not being removed. There is no space for depositing mineral. If there is less mineral, increased protein, then we say that the mineral content is less and it is hypomineralized. And why we see MIHR, is very, very commonly present in molars and first permanent incisors, because these are in the vulnerable period of infections and environmental insults. Like any defect from birth to 3 to 4 years will lead to affecting the molars and permanent incisors simultaneously. So what can be the etiological landscape? Ranging from prenatal, perinatal, postnatal factors and environmental toxicants and genetic and epigenetic influence. If you see that foundationally, the evidence for prenatal factors is inconsistent and weaker than postnatal associations. But still, some of the factors like the maternal illness and nutritional deficits are associated with MIH. And in the perinatal factors, we'll say that prematurity, low birth weight, and C-sec, these are associated with perinatal hypoxia, which can affect our sensitive ameloblast and then affecting the hypomineralization. And but the postnatal illnesses are actually considered to be the strongest factors leading to MIH. And the primary suspects are respiratory illnesses, ear and throat infection, systemic illnesses like the measles. Actually, any infection leading to hyperthermia and associated inflammation can directly interfere with ameloblast activity. And amoxicillin and erythromycin, these are the antibiotics which are, stated to be responsible for MIH. Initially, there was a confusion like whether the antibiotic itself or the infection is for which the antibiotic is being taken is associated with MIH. But some of the molecular level studies have shown that amoxicillin, erythromycin can interfere with the ameloblast function. Now, environmental toxicants. PPA, dioxin, heavy metal. In fact, the breastfeeding was also associated with the MIH. But then it was discovered that it has toxins, dioxins in the breast milk, which were responsible for MIH. And then any endocrine, because these all lead to endocrine disturbances and systemic oxidative stress, and this can alter the ameloblast activity, resulting in disturbed mineralization. And because of this, we say that the genetic susceptibility to MIH can also be there. And for postgraduates, I would like to say that some of the genes like the MLX, INAM, MMP20, these can be responsible for MIH. But we say that directly that genes may not be involved. But any epigenetic effect, like any environmental exposure, this can alter the genetic expression by methylation or hypoxia-associated responses, and this can affect the mineralization leading to MIH. But in the end, we say we actually do not know. We do not know what causes MIH. It can be a combination of all factors, and because the ameloblasts are very sensitive cells. But some of the factors which have been listed are these only: genetic, systemic, and environmental, toxic, and most important, epigenetic modulation. Now we have understood what is MIH. So let's see how to handle it from early diagnostic to holistic management. What all we need to bear in the mind that the tooth structure is different. It is not that you are restoring a normal tooth. The enamel is porous. It will keep on undergoing breakdown again and again. And because the child has been having sensitivity and difficulty brushing, and the defect has been present, you may have a poorly child with a poor cooperation, an anxious child who is not even allowing you to touch his tooth. And then dentist factor, I'll say that it is difficult to achieve anesthesia. It is not that simply you will give lidocaine and it will be effective. Another factor responsible for difficulty in achieving anesthesia is not just post-eruptive breakdown. Some of the scans have shown that the root canal system in MIH affected teeth is having a great deal of networking. Like the lateral networking is a lot more compared to a normal tooth structure, normal root canal or pulpal system. So it may also lead to hypersensitivity. Another factor is we need to observe the warning sign. And the warning sign is what? The hypomineralized second primary molar. So what happens that the mineralization window, first permanent molars, it overlaps with a little bit with second primary molars as well. And so if a defect is happening in second primary molars, you have to see that there are chances that this first permanent molar may also be affected. But because of the little overlap only, when you will see that the defect is very, very mild in second primary molars, okay, initially, and while it may present with a severe defect in first permanent molar. And so if we are observing a young child with HSPM with hypomineralized second primary molar, I will say that keep the child on a follow-up. And in case you are not able to keep the child on a follow-up, then at least observe the child as 8 years of age. That is the diagnostic window when our first permanent molars and incisors are fully erupted and you can observe them. Now, if you say that how it is happening, like what is happening, there are 4 pillars of management, like from the early detection to definitive care. Initially, you would say the risk assessment. Then, because if you are seeing that there are risks like the hypomineralized second primary molar is there, and you are expecting the first permanent molar to develop, so you have to assess and keep the child on follow-up. Then, if the defect is creamy white opacity, yellowish brown opacity, then prevention and remineralization. It is like you can promote the use of regular fluoride toothpaste and topical fluoride, and CPP ACP can also be used to achieve the remineralization. CPP ACP has been found to be very, very effective for this. Even SDF can be used. But then in case the tooth is not completely erupted, then interim stabilization and definitive stabilization, definitive therapy when the tooth is completely erupted. You see these things like the treatment algorithm for first permanent molar. If you see intact opacities, no PB, then seal the tooth, apply topical fluoride, apply CPP, ACP. And you can use resin-based sealers. And then if the defect is moderate, but the tooth is not erupted, then you can go for interim GIC. But if tooth is erupted, prefer composite. In case of severe defects, cuspal involvement, you can go with reformed metal crown and indirect laboratory restorations like the cast metal composite onlays. Unfortunately, in case the defect is even more than this and you are not able to restore the tooth, then you have to schedule the extraction. Now, how do we choose whether RMGIC or composite? I already told, if a tooth is not completely erupted, then go for glass ionomer resin modified GIC. Why? Because you are not able to achieve the complete isolation, while composite requires absolute isolation, technique sensitive. Well, if you leave the tooth with defect, because it is prone to more defect, it will continue getting, the PB will continue to get more severe, and while the intervention is required at this stage. And moreover, the GIC relies on, it does not rely on perfect enamel architecture, so it will stick to tooth. And we'll say that composite is micromechanical. It can be difficult to attach to this protein-rich MIH enamel. But then what do we do? If I am saying that if a tooth is completely erupted, then choose composite and not GIC. But then at the same time, I'm saying with composite, the adhesion is difficult, the bonding is compromised. So how do we go about? The bonding is compromised because of the proteins are there and they are blocking the pores. And when they are blocking the pores, they are not allowing the resin tags of the bonding agents to be formed, which are very, very critical, very, very crucial for bonding. So how do we solve this problem? We solve this problem by a very simple technique, the bleach, etch and seal technique. So before you are applying your etchant, use your bleaching agent, use sodium hypochlorite to dissolve the proteins, and then apply etchant and then save the tooth. And in case you have full coronal breakdown, then go for this thing, stainless steel crown and full coverage crown. It prevents further breakdown. And so if there is extensive post-eruptive breakdown, multiple surface involvement, and multiple times your direct restorations have failed, and so post-effective treatment modality stainless steel crowns. Otherwise, you can always go for CAD-CAM restoration, ceramic gold base, and these days I say that CAD-CAM restoration and indirect restorations are also accessible in almost all of the institutions, and these will offer you superior marginal adaptation and long-term solution, and maybe technique sensitive but manageable. And while doing any restoration, even the composite or indirect only, or superior marginal adaptation and long-term solution, and maybe technique sensitive but manageable. And these are some of the pictures showing the resin modified resin-based sealant, and this is resin modified GIC-based sealant. And this is a picture showing the cast metal only. You can see that we have extended the defect to the sound tooth surface. This is also very important while doing any restoration, even the composite or indirect only, or in MIH affected teeth. If we are going to place the margins only in the defect, like we are removing the defect and then we are restoring, but the boundaries of the defect, those are still weak, and these boundaries will keep on undergoing breakdown, and these will lead to marginal leakage, and your restoration will fail. So although it is not very, I'll say, not a minimal invasive dentistry approach, we intend to place the margin in sound teeth. We'll show in coming slide. Like here, the defect is here, and we have placed the margins in sound tooth here. Okay, not immediately after the defect is finishing. Then we have placed the composite restoration. Now you're saying that I'm talking again and again, like the restoration will fail, but how frequently the restoration will fail? So the data is showing that the teeth are prone to have retreatment 3 to 4 times more often than a regular teeth. And in case you are not able to salvage the tooth, then you can go for extraction of first permanent molar, but obviously in consultation with an orthodontics. And what is the ideal time? It is 8.5 to 9-year-old, because at this time the roots of the second permanent molar are forming, and we can expect, if we are extracting the first permanent molar, the natural visualization and space closure can happen with the second permanent molar. I'm running short of time, I'll cover it quickly. And if we go for anterior incisors, then in case the opacities, these are more of aesthetic concerns only. If opacity is shallow, creamy white opacity, simple microabrasion will solve your problem. And if these are moderate defect, then you need to combine your microabrasion technique with a bleaching technique. But in case there are more severe things, then you can go for microabrasion with resin infiltration or direct or indirect composite veneers as well. So if we see in this picture, this is an H-pledge seal. So first we are applying the bleach, then etching, then we are applying the resin. And so if you see, the defect is, gone or minimal now. This is microabrasion for yellowish brown opacity. This is microabrasion followed by composite restoration. And this is again microabrasion followed by a shallow veneering. And in this, I'm showing the resin infiltration, not my case. I've cited the paper, you can refer to for detailed technique. Here we are first, etching with 18% hydrochloric acid. Then we are applying our icon, that is the resin infiltrant, and then we are removing the excess resin using the flows, then curing it, and it is done. Now, what are the anesthetic problem? We'll say that chronically inflamed, sensitized pulpal tissue and altered nerve pathways render the standard infiltration and block techniques highly unpredictable in MIH. So what we do, preemptive analgesics. So it will lower the baseline inflammatory response and raise the pain threshold a bit. And then Articaine, 4% articaine is preferred for its superior penetration and efficacy. And also we can have supplemental intraligamental anesthesia for MIH cases. And so the clinical blueprint is like we have to be prepared for a lifelong trajectory because it is not that one tooth is involved. If one tooth you are doing the PEB restoration, other may have obesity, you need to follow it up so that it doesn't develop the PEB, and you have to diagnose at 8th age, and you have to be guided by presence of second primary molars or hair mineralization in primary molars. Here I will say that it is not only that second primary molars are affected, but we have published papers showing that almost any teeth in the primary dentition can be affected. Then the escalation for the treatment is severity based, and it is a holistic care. Like the orthodontic foresight long term is very, very important. And I'll say that it's not just an enamel defect, but a lifelong restorative and preventive therapy. And it requires comprehensive and minimal invasive dentistry approach. And thank you for your attention. You can email me your questions at the displayed email address. Thank you.
Thank you so much, ma'am, for such an insightful lecture. Ma'am, I can see a couple of questions in the chat box. The first question was, can we bleach MIH affected teeth?
Thank you, Dr. Pavitra. We can, definitely bleach MIH, but bleach alone is not going to be effective for MIH lesion. Rather, it may lighten the natural or the sound enamel and the contrast will be increased. So bleach in combination with microabrasion, bleach in combination with resin infiltration, that is going to be the efficient technique for MIH lesions.
Thank you, ma'am. And ma'am, what would be your insight on diet and MIH? Are they related?
Diet, I'll say there is no direct correlation of diet with MIH. Rather, breast milk. But in the breast milk also, the environmental pollutants like the red dioxins have been stated to be involved. So diet with pollutants can have an effect on MIH. And one more thing is that vitamin D deficiency has also been linked with the MIH. And as I emphasize that any insult to amyloblast, so any malnutrition, any kind of nutritional deficiency that can affect amyloblast, but no direct correlation has been reported till date.
All right, ma'am. Thank you so much. Can we have ma'am's certificate, please? Ma'am, this is a token of appreciation from the ISPPD. Thank you for your valuable contribution, ma'am.
Thank you.
So with this, we move on to the last session for today, pain management in pediatric dentistry. So we have Dr. Deepa Gurunathan, who completed her undergraduate from Tamil Nadu Dental College, Chennai. Ma'am completed her MDS in Manipal College of Dental Sciences, PhD from Savita Institute of Medical and Technical Sciences. She is presently working as professor in the Department of Pediatric Dentistry and Associate Dean of Research in Savita Institute of Medical and Technical Sciences. Ma'am has published more than 200 research papers in both national and international peer-reviewed journals, indexed in PubMed, Scopus, and Web of Science. Editor-in-Chief for the International Journal of Periodontic Rehabilitation. We welcome you, ma'am. Can we have the presentation, please?
Yeah, thank you for the introduction.
Yes, ma'am.
afternoon, everyone. This is the last presentation for the day. I do understand it is quite tiring after 2 long days, but this pain management in pediatric dentistry is an important topic as well. It is overlapped with various other topics also. Now, why pediatric pain management is essential? Pain in children affects much more than the immediate dental procedure. Untreated pain can alter the eating, the sleeping, school performance, and overall quality of life. More importantly, painful experiences during childhood creates a long-term dental fear and altered pain perception. So it is our duty to have an effective pediatric pain management for treatment success as well to develop a positive future and dental attitude. Coming on, all of you know why does pain occur in children? The dental pain mostly is due to dental caries with pulpitis, which accounts for 65 to 75% of the cases. And you know that might be a spontaneous pain, it can be nocturnal pain, or it can be only pain during food lodgement or only sensitivity. Around 15 to 25% of the cases might be because of pulpal and periapical infection that leads to a throbbing pain, swelling, tenderness on biting. The next most important, which accounts up to 30%, is due to traumatic dental injuries. There's always pain because of the eruption of the tooth. It can be either the primary teeth or also during the permanent teeth. Now, this will be only a mild gingival discomfort. During pubertal stage, there can be gingival conditions that can be leading to the chronic pain, which is experienced by children, that can be accompanied by bleeding and localized discomfort. Now, 5 to 10% of the cases, as we see in some few of the nutritional deficiencies or due to traumatic ulcers, we see oral ulcers, which can be aggravated due to the eating or while speaking. Now, when children undergo orthodontic treatment, they also bear these ortho pain. Now, why these things we need to know what causes the pain is because how do we treat it and where do we actually intervene to improve the pain perception of the children becomes very essential. Now, the classification of oral facial pain during duration, you all know it is either acute or chronic. With a time gap of 3 months, we call it of chronic nature, or it can be due to either cause. The nociceptive pain, those due to inflammatory pain or during the neuropathic pain. Okay, now coming on to what are the factors that influence the pain perception in children. Now we have to understand the factors, the causes will all have interlinked with each other as well as the pathway of dental pain. So we need to understand to know the these factors so that we will be able to hit the target directly. Now the factors that influence, all of you know, is that the age plays a very main factor because young children will perceive pain more aggressively and differently. If the child is having the anxiety and fear regarding the dental treatment, it amplifies the pain perception. Now to say parental anxiety will also have its influence on the child's behavior and fear. Now these which are based on emotional things which influences the pain perception, we need to understand because this has a different route to how we are going to manage the pain. Now, the previous dental experience, the pain memory will alter the pain perception also. Now, we have seen children who have less attention and the distraction. So, in those children also, we expect a different level of pain perception. Now, we have seen the various causes of pain. It can be either the inflammation or infection. Now, this we have to understand because where we are going to target to reduce that pain. Now, coming on to our own, the pediatric dental setup. that itself will help us to either instigate the pain or it can calm down the child for the dental treatment. Above all is the behavioral temperament, where we have read about more on behavior of the child, the psychological nature of the child, where we have seen whether the cooperative children have better mechanisms to cope up. Now, I was saying about the factors that were causing the pain, the causative factors that include the pain, and I was also mentioning about the pain pathway. Now, pain pathway is very, very important. This you know it also very well, since from the source of pain, where the peripheral nerve ending is there, we have the neurons that travel to the spinal cord, where we have the trigeminal nucleus caudalis. Now, this slide will be helping us to demonstrate the trigeminal pain pathway. The pain signals is originating from the pulp. Now we know that they are going to be A delta and C fibers. These go on to the trigeminal ganglion, the spinal trigeminal nucleus, then to the thalamus, and finally to the cortex. So these areas or these locations we need to remember. So when we see this slide, it is for us to easier to remember. We have the input signal for the signals to reach the nociceptors of the teeth or the oral facial structures that are activated by the stimuli. So that will become your decay or the temperature or the pressure. So as we see earlier, we have the A delta fibers which carry the fast sharp pain, and the C fibers which carry the slow dull pain. After that, you have the first point, that is the central relay, where the peripheral fibers will start entering into the brainstem at the pons. Either they ascend or descend into the Lysius tract and spinal synapse in the spinal trigeminal nucleus. The next one comes your second order neuron, where the primary afferent synapses into the spinal trigeminal nuclei. Now here the pain and temperature fibers will end in the medullary part. So after this they go above it, where it is ascends to the thalamus. Here the signal ascends at the trigeminothalamic tract, and finally the pain perception is felt only at the somatosensory cortex. Now here the signal reaches the cortex, where the pain is perceived and it is. So in the pain pathway, adults or in the child, from the tooth to the cortex, there are various stages where you have the transduction, where the noxious stimuli will be what we told the pulpal or the peripheral region. When it is stimulated, we call it as transduction. Then it has to travel. That is called transmission. Where here is an important stage where it is called the modulation, where the signaling is modulated. Either it can be inhibited or it can be aggravated within the central nervous system. After that, the signals are sent to the, as we saw, the sensory cortex, which will be telling you whether it is very painful or it is less painful. Now, learning about the transduction, the transmission. So we had seen what is transduction, what is transmission, what is modulation, and what is perception. Now, these four terms we need to remember. We have to remember those. If you see this diagram, there is a trauma or there is caries. So it is stimulating the peripheral nociceptors. So you know, if there is caries, it's going to be an infection. So your anti-inflammatory drugs, your local anesthetics can act over these peripheral nociceptors. Your local anesthetics can also act on the peripheral nerve. But beyond this, where the nervous stimulus is going up to the dorsal horn of the spinal cord, it will be acted only by your opioids or alpha-2 adrenoreceptor agonists, sometimes even your local anesthetic. Now, when we have to target the sensory motor cortex, please remember only an opioid can do. Now, you have to remember this term opioid and with the sensory motor. So, is the pain pathway in children, is it different? It is different because the modulation pathways are still immature and they are still under a greater influence of emotions, as well as the pain memory in relation to dentistry will be developing very easily, and there is an increased sensitivity to the painful stimuli. Now, this thing called anxiety, it can be anxiety from the patient side or from the parent side. Now, what does it do? It increases the attention to the painful stimulus. If fear increases the sympathetic activity, you would have seen the child who is very frightened will have an increased muscle tension. So all these things will lower the pain threshold. So here the behavior guidance, whatever we do, can help to reduce the pain, perceived pain. Now, this is what we saw in the first slide itself, how the behavior of the child or how the cooperative level of the child can influence our pain management. Now, the behavior guidance technique like your tell, show, do technique, positive reinforcement, modeling, or the parental presence there can reduce the anxiety and reduce the perceived pain intensity. Now, on developing more of anxiety and fear, because that is a major perspective which we will keep on looking at, it will be the parental fear will affect the child's behavior. If the mother is very scared of the dental treatment, we have seen in literature those parents do not bring the child himself to the dental treatment. Now, these negative experiences also increases the child. Okay, we had seen earlier the pain pathway. So there should be something which is controlling all these nervous stimuli or the impulses which are traveling. Now, that is called the gate control theory. Now, gate control theory is, you all must be knowing it very well. To make it very simple, it is a virtual gate that is present in the spinal cord, which will help us either to give an aggravated pain sensation or a slightly lesser pain perception. So we had already seen there are A beta fibers as well as the C fibers. Now, stimulation of larger A beta fibers through vibration or through pressure will inhibit the transmission of pain impulses. Now, the sharp pain is carried by the small nerve fibers. So, when these A beta fibers are aggravated, this will lead to the minimizing the pain transmission by other smaller fibers. So this forms the scientific basis for vibratile devices, the distraction techniques, and the methods that are used in the Buzzy device. So here, if we see, we have all these devices. We have the spinal gate. So there that gate will either open, if we have more influence on these bigger fibers, that will have a major effect. Sometimes these gates also open for if there is a bad experience earlier or the child is in anxious mode. Now that itself can produce the catecholamines, the cortisols, which will open up the gate from the impulses that are traveling through the descending tract. Now, this can also cause the gate to open and there will be an increased pain perception. So here when we come, these vibratile device, they use deliver micro oscillation to close the gate during injections. Now buzzy device we have, it gives a high frequency vibration with cold pulse. So there also the stimulus is the same, but that stimulus is inhibited by a much higher one. So like your high frequency vibration, therefore the pain and anxiety, perception is reduced. You have the cryo anesthesia. So before injection, if you give at the point of the needle, so that will also result in the reduction in the pain perception. Now we have our virtual reality and immersive destruction flood. It floods the brain sensory processing channels, leaving less attention for painful stimuli. So hope this is clear. Why we have to know about the pathway and why we have to know about the gate control theory, which influences or which establishes the need for our advanced agents that will help to reduce the pain perception. Okay. Now this is very important. As we had seen earlier, the pain is of a major thing that cannot be just ruled out by your analgesics. Since we had already seen this pathway. Now at each level, what can be done? Now you have your primary afferent input, where it can be either your pulpal or your oral mucosa or the periodontal ligament. And at that area, we had seen earlier that yes, we can give you local anesthetic infiltration. If it is inflammation, you can go with your anti-inflammatory drugs. Now, how do they act? These local or topical anesthetics, they prevent the nociceptor activation. And the anti-inflammatories will reduce the peripheral inflammatory media states. When it comes to the first central relay at the trigeminal ganglion, your local anesthetics and anti-inflammatory drugs can work. Coming on to the second order neuron, where you have the pars caudalis, that is in the brainstem. There we need to have your NSAIDs and still remember this opiates. But after that, it is going to be a much more pharmacological one, like either the sedation or the general anesthesia. Here, it should reduce the central transmission, and thereby it raises the threshold for pain transmission. But if we have to do something to reduce the anxiety, to modulate the cortical processing, then we have a higher level of sedation as well as the general anesthesia. Now we had already seen that the sensory cortex is here the pain is consciously perceived, localized and interpreted. We can try to alter it through distraction methods, your cognitive behavior, parental presence, or the tell-show-do technique. And with if it is much more severe pain, it can be reduced with your nitrous oxide or general anesthesia. Now this slide becomes very important, because if a question is asked, giving a scenario based, if it is a 3-year-old child and the child is having severe dental ache, and this is a treatment that has to be done. So just giving an answer as an analgesic to be addressed will not be sufficient. We need to address all these factors, and your answer should be complete. So what are the methods of pain assessments? This depends on your age and the cognition of the child. The behavior, so we have the behavior and self-report methods that have been used. Plus we have our facial scales, which things about the expression and crying. And this becomes very essential before treatment itself, so that we can understand how much pain is actually there. It can be either during the treatment or also after treatment also. But before treatment, it's very essential so that we are in a safer place to treat the child, so as the child will be more cooperative if our level of treatment is reducing the pain. Now, this FLACC scales are useful in pre-verbal children, while the Von Becker's faces scales help younger children express the pain visually. Older children may use visual analog scale or the numeric rating scale. Now, no pain scale is ideal for every age. Therefore, age, emotional maturity, the clinical situation in which we are, it should be always considered while selecting the appropriate assessment method. Now, these things we already know it very well. This is just a revision. So, you need to understand at what age which pain scale will be very much useful. Now, apart from these visual analog scale, the faces scale, you have something called the autonomic measuring the measures that can be used also for assessment of the pain, which can be your heart rate, the blood pressure, and these can be used to detect your acute pain, the surgical pain, the chronic pain. As well, nowadays we have started to seek for, which is more of in the research part, like your stress hormones, like the cortisol and the epinephrine, which can be done for all the ages. But it is a non-specific and it is changes unrelated to the pain. The pain need not be only in the tooth or anything, but it can be elsewhere also, by which the parameters can change here. So what are the principles? Of course, we all of us know that the prevention is the ideal approach, but pain control is essential in the pre, intro, and in the post-operative. The combined pharmacological and non-pharmacological method should sufficient is very, very important. As we had seen, the pain travels through pain before it is perceived, it travels through a long part, and there are various locations at which we can intervene. The reduction of fear and anxiety itself will lead to an improvement in the pain perception. So what are the non-pharmacological methods? Your behavior guidance, which will increase the cooperative levelness with reduction in anxiety and pain perception. Now this has to be worked along with the pharmacological. So yeah, we have our behavior methods, your virtual reality, of course, the hypnosis and acupuncture elective cases. Now, these also we should know where to use what. Now, tell, show, do, take. So when the question is asked on tell, show, do technique in a short answer, we need to be able to tell what it is and how does it act. Now, this is important, the mechanism. It basically reduces the anxiety. It gives a sense of control and predictability. The child knows what is being done. But this, if you see, it is at the sensory motor level, at the prefrontal cortex activation. Now, this can be done in all age groups, but preferably from about from 4 to 8 years will be better because they will be able to understand. Now you have the other methods like the positive reinforcement, the distraction techniques. Now this also all come in the same age group. That way we can remember. And if you see the distraction technique, yes, the gate control theory will be helping. Here it reduces the activation of the brain processing center because the child is distracted to something else. So in this way, we need to remember which part, like your deep breathing activates the parasympathetic vagal response, so it increases the pain threshold. Now, voice control we are no longer using, but with the consent of the parent, if we use, it will generally provide a sense of safety as well as it reduces the anxiety and it reduces the sympathetic arousal. But it should be, our voice should be very calm, firm, and confident with clear instruction. Now, sometimes the presence of parent by itself will give comfort to the child, both physical and the verbal support. It will be increasing the oxytocin release, decreasing the cortisol release, giving an emotional security, which lowers the pain perception. Now, we have the These when any one technique is asked, then we have to remember to tell how do we do it, for which age group we do, and with what mechanisms we can have a mechanism of pain reduction. It happens. So vaguely do just by giving examples will not be much more marks. Now these are the other techniques. Here we saw the vibration technique, the cold applications at the site, where it is more of to do with the gate control theory. So here the newer ones or advancements which have been said is with the aromatherapy and the pleasant odors, which will be modulating the limbic system. It reduces the anxiety and stress hormones, thereby promoting the relaxation. Now these are for all the age groups, but these are once again more and more, they are more effective to a certain age group like 5 to 8 years, where they are in a state of anxiety and fever, plus they will be able to cooperate with us. Of course, the vibration techniques and placing cold will be helpful for any child who is having needle phobia. So in advanced pain control technologies, you have your Buzzy device, the dental wipe, the wiper jet, quick sleeper, intranasal tetracycline, the oxymethicillin spray, which can reduce the by the child. Now coming on to the pharmacological management, of course the first line of drugs is your NSAIDs and acetaminophen. Ibuprofen, all of us know, is a commonly preferred drug. Why? Because of its anti-inflammatory property. Combination therapy is also provides superior analgesia, but however, we do not do a combination therapy unless otherwise there is an extreme pain, because we try to treat the patient before and so if there is any infection, if that is treated by itself, the causative factor of pain reduces. So combination therapy, though it is very good, it's not essential in all. Yes, all of us know how to calculate the drug dosages. We have by the body surface area, by age, what is the loading dose, what is the maintenance dose. And for very young children, we give the syrup and the liquid. Now here we need to calculate how much of medication is present in 1 ml of syrup. So accordingly, we give each one depending upon the weight of the child. Now, when we are calculating the drug dosage, it becomes very important. We are not going to see the surface area, but the child's exact body weight. We do not assume the weight to be 20 or 30, but we have to weigh and see. Know the drug, its pharmacokinetic and the pharmacological activities. You calculate the dose that is required. If it is in terms of a syrup, the volume that is required. See at what interval it should be given and at what frequency it should be given. More importantly, we have to check in for the allergic nature of the child, as well as if the child is having any chronic diseases like kidney failure or things like that, then we have to be very careful with our drugs. Now, are commonly used for once we know the ibuprofen, we are giving antibiotics. I will tell you, antibiotics is not an analgesic. So if we give only antibiotic, will the pain reduce? No, we need to do the treatment. Maybe it is adjuncted with an antibiotic as well as an analgesic will help in the reduction of pain. So here this is a chart which gives you about the analgesic therapy, at what dosage we have to give, the time at what we are able to give the analgesic. Now sometimes there is some called a preemptive analgesia where we can give 30 to 60 minutes before the procedure. This is proved to have a lesser pain perception. Now commonly used drugs. This can be one of your short answers. You will be using your the Brufen, the paracetamols, and then naproxen, the diclofenac. Remember what is to know the pediatric dosage at what intervals do we have to give, and we have to be very, very clear about the maximum daily dose. And in our prescription, we need to have whether it is a syrup or it's a tablet or it's a suspension. As well as these adverse effects, it's better to inform the parent beforehand itself what can be the side effects of these drugs. So we did see opioids, and if all of you all remember, the first slide was with the first few slides where there was a neural pathway, the pain pathway. At the cortical level, it was told opioids. It's very much restricted in children. Why it's restricted? It is the risk of respiratory depression. So we are going more towards the analgesics. Now this slide will be helping. It's a overall one. So we have your non-pharmacological strategies. Then we have our local anesthesia. Our first line pharmacological drugs will be the NSAIDs. We can take up the combination therapy with ibuprofen and acetaminophen, and the codeine or tramadol is contraindicated due to its pressure. Coming on to a local anesthesia, which we use it very regularly. Topical anesthetics, we saw where it will have its effect. Then we have our local anesthetics that where it can act. So I'm repeating it. We need to know the pain pathway. So when we write, we can tell that this is the place at which the pain perception is modulated. The other techniques are the recent advances include your buffered local anesthesia, the computer controlled local anesthetic. Now, this computer controlled local anesthetics as well as the slow injection techniques improves the comforts of the. So, when we see the local anesthetics in pediatric dentistry, lidocaine is a commonly used one. Articaine is it's a very good one with the efficacy of the drug is excellent. We also use the prilocaine, bupivacaine, and the ropivacaine. We are very comfortable with the lignocaine and articaine usage where we use directly, but it will be in this also there is a maximum recommended dose per kg body weight. It's not like you can give how many ever mLs of local anesthesia to the child. So this we need to be very, very careful when we are administering the local children. So how do the local anesthesia will be reducing the pain? This will be very helpful for you when you're writing the advanced techniques in pain management. You have the topical patches, the intranasal spray, the jet injectors, the Oraverse. Oraverse is something which will be reversing the local anesthetic effect, because that is also very essential to prevent the post-operative self-injury. Then comes your sedation, which includes your moderate sedation to your general anesthesia. So here we need to remember what type of sedation we are giving, and these will be dealt, I'm sure will be dealt with you in more thorough manner in the other sections where they deal with sedation and general anesthesia. This is only an overview of what we have here. So when we see the moderate sedation, which is generally called as a conscious sedation, it depends on the length of the procedures and the cooperative level of the child, whereas your general anesthesia is for more of full mouth rehabilitation and very young patient where we see uncooperative children and there can be medically compromised. But these all things should be done only under constant monitoring, like either a pulse oximeter, your blood pressure, the ECG. If in case of deep sedation, you should have your capnography along with the presence of emergency drugs and resuscitation equipment. Antibiotics, are they analgesics? Do they control pain? No, they're not analgesic. They're useful only when the infection is systemic involvement, and by then you can treat the patient so that the need for deeper analgesics or antibiotics is avoided. Now, antibiotic stewardship is very, very important because the antibiotic resistance is now the opioids, as we see, has to be avoided. Aspirin should be avoided in children for acute pain management because there's a significant risk of Raynaud syndrome. Ibuprofen can be used for shorter duration and lowest effective dose, whereas acetaminophen can be used with the knowledge regarding the liver function of the child. When if there is some problem with the hepatic system, then this acetaminophen should avoid it. Now, this is something which we don't think when we call about pain management, but yes, we need to know about the oral ulcers. Now, these are also very painful. So, here to manage them, we need to know the etiology. Either it can be trauma, the trauma for why, because is there a sharp tooth, or is there an ortho treatment which is going on, or our actus ulcer which is mostly due to nutritional deficiency, or it is a viral infection. So we need to know the etiology to do the management. Mostly these, apart from managing specifically, we need to give a topical anesthetic for pain relief, but make sure to inform the parent that to use the topical anesthetic only during eating. Otherwise, this topical anesthetic by itself might cause a self-inflicting injury. Now, viral ulcers, they topical antiviral drugs can also be given. Now, this all depends on what type of ulcer and why these ulcers are caused. General management will be your pain relief, maintain a good oral hygiene, maintain a soft diet, adequate hydration is very, very important, and treat the underlying causes and see if it is healing and check for. Now, this is an overall picture of how at each age group and during what time will be we have to do the dental pain management. So, dental pain management is not one single word analgesic and it is over. No, we have to check for the age, the developmental characteristic, try out all the behavior management techniques, the local anesthesia, then you have your pharmacological techniques. So, as such, if we see the pain management in children, it should be an holistic one rather than just giving an analgesic, doing the treatment and off. So, it's a multimodal pain management where you have your distraction techniques, your local anesthesia, of course, your systemic analgesic, plus your since we are moving forward, we can use our advanced and adjuvant techniques to remind once again at what level of pain pathway are these going to influence the pain perception, that we have to know, because during answering the questions we need to be more. So the holistic pain management is not only pharmacological, it involves psychological support and behavior management. Ultimately, our goal is to be having a experience. Now, what are the general mistakes what we make during exams is when it is said pain management, we discuss only about the analgesic drug. We forget to determine, I've been repeating this in my lecture, do not forget your pain pathway. We forget what the age of the child is, so we don't talk about the anxiety and the fear. We don't talk about the parental experience. And sometimes we focus only on local anesthetic and forget the behavioral patterns. So those should be also included. And always have a multimodal approach, not one single approach for pain for one type of pain that is experienced by the child. And when we are mentioning the techniques, please explain the gate control theory, the cortical modulation, how the central sensitization happens. And it's always better because you have done for 3 years. When you've treated patients, you know the various type of pain, the various type of psychological management, the behavior management. examples. Now, this is a mind map for the entire lecture, what we had seen for last 30 minutes. This will give you a very clear idea of what are the key points that you have to remember. So these are the long answer questions that can be expected. And these will be the short answers. There can be many short answer questions that can come, but I have just divided into each category. So this will help you to revise when you are going through this chapter. Though this is not a very separate chapter, but you will know what to be said when, what to be written when a particular thing on pain management is asked. So basically it comes with the parental influence, the modifications, the modulation. If they're asking about the pharmacological management, they can ask about your local anesthetic. In any specific local anesthetic can be used. As well, we are more towards the recent advances now. So any of the recent advances can be questioned. So these are the references. And a big thank you to the ISPPD as well as the Postgraduate Institute of Medical Education and Research, Chandigarh. I thank Manoj sir also for coordinating well and to allow me to do this presentation. And wishing all of you the very best, not only in these exams to come, but in all things of your life. Thank you.
Thank you, ma'am, for your excellent presentation and compilation of the pain control and management. Ma'am, there are few questions has been asked by the postgraduate students. Am I audible?
Yes, sir.
Okay. The first question is, does the does the pain aggravate in lying down position? How to differentiate whether the child is anxious or fearful?
Okay. I think now I'll explain from when we line but
Ma'am, sorry, ma'am, your voice is breaking. Ma'am, you can reply to the questions in the chat box. Can we have the certificate, please? Thank you so much, ma'am, for your valuable contribution. Please accept this certificate as a token of appreciation from ISPPD.
Thank you.
With this, we come to the end of day 2 of rapid revision. Today's sessions were truly insightful and enriching, covering a wide spectrum of important topics in pediatric dentistry. I sincerely thank all our esteemed speakers for sharing their valuable knowledge and clinical experience with us. I would also like to thank all the participants for your active involvement and interaction. We look forward to welcoming you all tomorrow for another exciting day of learning. Thank you. Have a nice day.